I would ask you my last question of this conversation, that how do NIRAF and ICG affect patient outcome, especially for those with parathyroid-related complication during cancer treatment? Could you share any specific case where these technologies made a difference?
As you can see, the thyroid tumors such as follicular adenoma or Bethesda 3 and 4 thyroid tumors, which is suspicious follicular neoplasm or atypia of undetermined significance. This tumor can this tumor, whenever operated for thyroidectomy, they can be found to have a malignancy in a final histopathology report. So this type of patient comes to us for the completion thyroidectomy. Already patient's one lobe of thyroid has been removed and cancer has been detected. So during to operate this kind of a case, it is very challenging to us because of a scar tissue and a fibrosis of a previous surgery. So let me tell you one incident which I operated completion thyroidectomy before a month. So patient was operated for a right hemithyroidectomy and she was diagnosed to have a follicular thyroid carcinoma. So as tumor was more than 4 centimeter in size and there were many risk factors, we take it for a completion thyroidectomy. So after dissecting the thyroid, during opposite side where thyroid lobe was not there, we so injected the ICG and I could see there are only one parathyroid gland which was identified even before a dissection. Even there was a fibrous tissue. So on ICG angiography, there was no uptake and ultimately it was devascularized. So I auto transplanted that gland into SCM, and particularly on the same side which I operated, I confirmed the vascularity of two parathyroid glands, and I couldn't even identify before I started a dissection in that particular area. So even because of fibrosis and scar tissue, I would able to save two parathyroid glands and auto transplanted one opposite parathyroid gland, even beneath the scar tissue. And post-op course of the same patient was excellent. She didn't develop any hypocalcemia, even temporary. So this type of a cases where there is a fibrosis and a scar tissue as well as advanced thyroid cancer cases, ICG plays a huge role to save a parathyroid.
Right, sir.
It is simple. We should have a in this era of precision, we should have a objective criteria rather than subjective criteria to identify the important anatomical structures such as parathyroids, which is distinct glow under NIRF and the vascularity seen in ECG. And I think if anybody talks about evidence, we would not find any randomized data because control here is the surgeon's eye and rates of hypocalcemia, which is very rare to control to conduct this trial at very huge stage. So I would say objective evidence is the key and it should be beneficial to surgeon. This is not an optional. Surgeons who are using this believes precision is the key. That's why. Yeah.
I completely agree with you, sir, that precision is the new tool surgeons have with fluorescence guided surgery. And thank you so much, sir. With this, we have reached to the end of the session, and I would truly appreciate you taking time out and you're sharing your insights. And on behalf of Team IRILLIC, I would say thank you and thank you for your time today.
Thank you. Thank you very much.